All right, week 7 path neuro. So some basic review from A and P. The brain's got 3 parts to it, or not the brain. The nervous system's got 3 parts to it. The CNS, which is going to be the brain and spinal cord. The PNS, which has its 31 pairs of spinal nerves and the 12 pairs of cranial nerves that we all had to memorize in A and P and was a total bitch. We have the autonomic nervous system, which is the sympathetic and parasympathetic branches, so our fight or flight or rest and digest. I always preferred feed and breed. I thought that was more fun. Okay, blah, blah. I'm not going to worry about that right now. It is important because it coordinates emotion, memory, cognition, and learning. So, I mean, that's important. So we got the brain principal sections, which includes the cerebrum, the big ol' hunker on top, and all of its parts. The diencephalon, which is going to be the middle part with the thalamus and hypothalamus, our cerebellum, the little squiggly part down here for coordination, and our brainstem for all those parts for taking care of our need for breathing and keeping our heart rate going and all that stuff. And then we have the multiple sections of the cerebrum itself. We've got the frontal lobe, which is going to be good for complex thought, movement, motivation, sense of mortality. Temporal lobe has to do with our ability to speak and hear. Occipital is about our ability to see, and parietal lobe is going to be our sensation section, our ability to feel things, and also some memory and emotion stuff. Yeah, this never made sense to me. Fetal development. I guess the basic idea here is that neuroplasticity develops, or it exists in fetal development, in that the tissue in the brain develops into the tissue that it needs to have, based on how I don't know, it's so weird. But just remember there's a lot of neuroplasticity. That's the big word. Neuroplasticity in fetal development. It develops into whatever it needs to. And then as we age and become older, we have a decrease in cerebral blood flow, which is going to mean that we're going to have less of the fuel that we need to run our brain effectively. We're going to have a decreased number of neurons, as well as a decrease in the synthesis and metabolism of neurotransmitters. So we're not going to have as much in the way of fuel. We're also going to have a degradation in the concrete structure of the brain and in the signals being sent back and forth from one neuron to the other, telling them to do things. We also are going to have some natural degeneration of the myelin sheath. So that's going to be the thing that wraps around the nerve dendrites, axon, not dendrites, around the axon, and helps. And I think maybe I don't know. I don't remember. It helps to contain the signal that goes down, transmitted to the next neuron. We also have a decrease in astrocytes and the white and gray matter in general. And as such, that's going to lead to an increase in blood-brain barrier permeability, which is important for when we give medications, since certain medications are more blood-brain barrier permeable than others, and the more permeable the blood-brain barrier is, the more we're going to have the ability for substances to cross between the two. There's also a greater time to learn and process cognitive thought. They're great with, most of the time, older adults are known to be great with crystallized intelligence, but not with fluid intelligence, which is like the ability to quickly learn and adapt to new things. But their memory tends to be great. When we have an injury to nerve, something part of okay, yeah, I was right. So they got the oligodendrocytes around making the myelin sheath on the axon, not the dendrites, whatever. It's been a long time since I've done A&P. So when we have a severely injured CNS neuron, they generally don't regenerate, but the ones in the peripheral nervous system may regenerate. But it depends on how much of a degradation we have to that chain of neurons, and how much space there is between the two still alive and functioning neurons. When it comes to brain injury itself, we can have either a primary or a secondary brain injury, the primary being the actual direct insult. So someone takes a baseball bat to your head, the actual baseball bat caving your head in would be the primary injury. Let's say the baseball bat didn't actually cave the skull in, it just gave you a big old bruise inside your brain. The inflammation that occurs from the baseball bat hitting your brain will be the secondary brain injury, because the swelling inside your brain is what causes then ischemia, or a lack of blood flow to your cerebral tissue, to cause tissue death. So you get hit in the head, the concussive force of it causes damage, but then the swelling and the bleeding inside causes secondary damage. With a brain injury, like I was saying, we have ischemia and hypoxia. Depends on the size of the injury. With ischemia, this is going to end up leading to hypoxia, and together creates neurologic dysfunction. One of those types of neurologic dysfunction can come from, okay, all right, wrong way. So brain injury can also occur from ICP or increased intracranial pressure. Normally, the blood and CSF and the tissue all work together to form a intracranial pressure of 0 to 15 millimeters of mercury. This is very, very low. So basically anything that takes up space, increases that pressure, is going to make significant impacts on the tissue in the brain. So some of the things that can increase ICP are going to be including lesions, inflammation, edema, obstruction of CSF, or overproduction of CSF, which we'll get into more of that in a bit here. So we can have an increase in brain tissue volume. So if you have a tumor, we get a brain tumor that develops and it's building and it takes up space. It's part of the brain tissue, puts pressure on the brain itself. Hemorrhage, infection, edema, I don't know how those are brain tissue things. And if we can have hydrocephalus via either obstructive or non-obstructive. I don't know what a pseudotumor cerebri is. And then acidosis and high arterial PaCO2, not O2. High arterial PCO2 in acidosis can also lead to increased blood volume, which will then accumulate inside the head. So with our brain injury, we're going to have some pretty classic signs and symptoms, depending especially on the etiology of the brain injury. The increased ICP can lead to or present as a headache, changes in level of consciousness. That's very, very common. The eyes may have some issues with being able to track movements, may have issues with one pupil being bigger than the other. Seizures are very common. We may see changes in vital signs, such as Cushing's triad, which you can't really see here. But Cushing's triad is a very important thing to remember about brain injuries and increased ICP. So Cushing's triad, which is very different, very, very different than Cushing's disease and Cushing's syndrome, is going to be a showing of bradycardia with hypertension or with a wide pulse pressure, which is another way to say it, meaning that you have a high systolic while having a low diastolic, and then erratic respiratory rates. So a lot of this is due to the pressure that builds up on the brainstem. Other issues we're going to see are posturing, such as here, this is decerebrate posturing and decorticate posturing. I've always learned them as being on a spectrum, with decerebrate and decorticate being at the lowest, most portion of a spectrum, a gradient, and decerebrate being, which is this one, being the most ominous sign, and decorticate being just one step above that in regards to how ominous it is. So this is the last thing you'd want to see, aside from just plain old completely unconscious and flaccid. But I think there might be some updates to indicate that they dictate which part of the brain is actually affected by um, the brain injury. So, and in infants, we can have a bulging fontanelle. That's something to look out for whenever you're checking kids. Um, changes in speech, vomiting. And as they increase in ICP, we're going to see those changes in consciousness, changes in pupillary responsiveness, altered respiratory patterns, and they are potentially going to be and may lead to being unresponsive to stimulation, unable to move or verbalize. And really depends on what kind of brain injury we have, how long it's been going on for, and how quickly it's degrading. So when we have someone with a brain injury, we're going to want to quickly diagnose it via CT is our main thing, but we'll also consider using MRI. If they have a lesion or a whole bunch of extra CSF, we'll remove that. And then we also really want to focus, and this is a big thing, on managing cerebral oxygenation, because if the brain runs out of oxygen, it will die, and it will die very quickly. We also want to make sure they have glucose, because that's the two things that the brain runs on, glucose and oxygen, but glucose isn't the problem here. TBI, or traumatic brain injury, is very, very common, thanks to football and sports in general, but football is the main problem. Dudes are very much at fault for most of the TBIs due to taking high-risk activities, but also transportation accidents are very common, falls, firearms, sports. A lot of these things seem very guy-related. And TBI indicates here that the Glasgow Coma Scale, or GCS, is used specifically for TBI. Glasgow Coma Scale is actually used for a lot of patients, if not most patients. I've used them before for every patient because it works great for showing just how sort of with it a patient is. So a scale runs on a spectrum from 3 to 15 and is based off of eye movement or like alertness, a vocal ability, how well you can speak, and general movement or posturing. So you add up all the three different columns to give your total score. Mild will be 13 to 15. People in this range, not really a big deal. People in this range are starting to really be concerned about their current state. And then 8 or below, really, really bad. So, and in pre-hospital setting, generally the saying goes less than 8, intubate. So if you have someone with a GCS score of 8 or below, or under 8, then you're going to want to look at taking care or taking control of their airway, their breathing, ventilation, because there's a good chance that they're not going to be able to pretty shortly. So traumatic brain injury can come from a concussion, which is normally more mild and self-limiting. You get checked out just to make sure that you don't have any bleeding. It's very common in athletics, thank you football, and you can have even a loss of consciousness of less than 30 minutes. But generally not a big deal. But having multiple is a big deal, as we've seen long-term with people from the NFL. You can also have it as a contusion. That was not what I wanted to do. And when you do a CT or an MRI on someone with a contusion, this is going to reveal an area of brain tissue damage. And I think that's what this is right here, is a little contusion, maybe a hematoma. It's like a bruise. So a contusion is going to be a bruise in the brain. Intracranial hematoma, that was weird. Intracranial hematoma is also a cause for TBI, and this is going to be a definite bleed in the brain of some form, a collection of blood within the cranium. And there are 3 types. We got our epidural, subdural, and subarachnoid. There's something going on with these that disrupts the vasculature. So they either burst because of external forces or from internal forces or just something not going right. And which one it is will dictate, or where it is in the brain, specifically in regards to between the layers of the dura, will dictate whether it's a slow or rapid progression of a bleed. And all of that together can lead to an increase, massive increase in ICP. So an epidural hematoma is going to be where we have an arterial bleed. And because it's arterial, that means it's going to be a very rapid bleed. So they're going to have a rapid onset of symptoms. It may appear to be a minor injury. It leads to a brief loss of consciousness. Maybe people thought it was a simple concussion, but then all of a sudden their consciousness rapidly deteriorates, and they may end up bleeding out and die. The treatment is to open up this area and remove the hematoma from there. So these are people who you pretty quickly know that something bad's going on and we got to act fast. Subdural hematoma is going to be a venous bleed. And so, oh, and to backtrack here, the epidural bleed, this because it says epidural, that means it's above all the different layers of the brain. It is simply between the dura mater, which is the outermost covering of the brain, between that and the skull. So the actual brain tissue, all of it is beneath the hematoma. Whereas in a subdural hematoma, this is going to be where we have a pooling of blood, venous blood, between the dura mater and the arachnoid mater. So this is going to be right underneath the very top layer of the three meninges. This is going to be a problem compared to epidural hematomas because they are very frequently missed. The problem is that you get a concussion, you go to the hospital, you get yourself checked out. There's nothing to see because there hasn't been enough of an accumulation of blood to identify that there is a hematoma that needs to be dealt with. So they say you've got a concussion, go on home, you're fine, just don't take any medications, like I don't even know what at this point. Keep an eye on it, let us know if it changes. But then 3-4 days later, suddenly you are on the ground unconscious because you had this massive accumulation of blood that pooled inside your head over the course of 3 days. And now you're dead. As we have an increase in ICP, we're going to develop a headache, vomiting, blurred vision. And so these are really important things to let our patients know when we are discharging them under the assumption of having a concussion, because this is what we need to look out for. When we do observe that there is a definite subdural hematoma, the treatment is to then remove tissue and the clot that is present there, because more than likely there's been clotting because of the long-lasting level of blood stasis. Next we have our subarachnoid hemorrhage, or blood bleed, or hematoma. Why is this one okay, whatever. Subarachnoid hematoma. This is one of the scarier ones because this can occur from nothing that anyone actually ever does to themselves, from like an external factor. This is going to be an arterial bleed that also comes on quickly, and this comes from oftentimes cerebral aneurysms or arteriovenous malformations. So the cerebral aneurysms, that's going to be like right here. That's going to be this little pocket of artery right here. So this is how it's supposed to look, nice and tubular. But then part of the tunica muscularis, the muscular part of the artery, weakens. For whatever reason. There could be maybe hypertension, cancer, any number of things. And so part of the wall weakens, probably I think mostly the tunica muscularis, and it bulges out and has a super weak, super thin layer of blood vessel wall there that is very susceptible to popping. And depending on which part of the blood vessel pops will determine how much blood is released and whether it is a very rapid, like you're dead in a matter of minutes, hours, to know we can actually manage this and save you. So that's going to be what a aneurysm is. And you can think also of an aneurysm as the AAA, the abdominal aortic aneurysm, which is you might be dead in a few seconds because of how massive a blood loss you can have from that, or aortic dissection. Both of those have similar presentations and outcomes. An arteriovenous malformation is going to be a little bit different. This is where we have So instead, what we're supposed to have is the artery travels, it splits off into a whole bunch of capillaries, a lot of capillaries. Those capillaries come back together to form a vein, goes back to the heart. Instead, with a AVM, we've got an artery that goes straight into a vein in the brain. An artery is meant to be able to handle a much higher pressure of blood because it's coming directly from the heart. When it goes into a vein, that vein is not designed to manage that high a pressure volume. And so over time, that vein will end up becoming weaker and weaker and may end up bursting because it just can't manage the stress that that artery side can. So with this, we've got blood that spreads throughout the CSF. We may end up getting meningitis or meningeal irritation, hydrocephalus, water on the brain, headache, vasospasms, ischemia. This is not something to mess with. If you suspect it, get them to a hospital, and hopefully we can save them. So with CNS infections, the most common of these is going to be meningitis. And these occur from any kind of organism that gets in there, viral, bacterial, fungal, into the bloodstream and manages to get into the CSF. With meningitis, bacterial is the most common, and this is going to be Streptococcus pneumoniae or Neisseria meningitidis, pneumococcus or meningococcus. We can also have it from a cerebral abscess that opens up and spreads into the brain, or encephalitis from a virus. Don't know much about those. They've never really been that important from what I've seen, but they're on here, so they're important. With meningitis, yes, hi. The bacteria, either pneumococcus or meningococcus, invade the leptomeninges, which means one of the three meninges, causing inflammation. The key signs for meningitis is going to be nuchal rigidity, which is a stiff neck, headache, photophobia, and high fever. Those are like the classic signs of meningitis. There are a number of other ones, like we can have headache, altered mental status, phonophobia, and a hard time listening or hearing, or being very sensitive to sounds. And then a rash is also pretty common, but not always guaranteed. And that's mostly if we have a meningococcal infection. This is a telltale sign as well, and it's something to, if you see it, get into a hospital as soon as possible. We're going to diagnose via a lumbar puncture, and at first we're going to tell at the lumbar puncture in CSF that we have an elevated white blood cell count. Then we're going to use that CSF to culture and find out what specific strain or etiology do we have of causing meningitis. We will likely, after the CSF starts, give them IV antibiotics, a broad spectrum, something to ensure that we get something started because they're at very high risk of disability and death. Supportive measures, maybe corticosteroids, but evidently that's controversial. I've never known because I've never treated it with that. We also always want to promote prevention via vaccinations. And as you can see here, people with meningitis are at risk for gangrene. And the reason for that is because people who have meningitis, especially bacterial meningitis, are at risk for developing sepsis. And with sepsis comes the activation of the coagulation cascade, which can lead to an inappropriate clotting condition called disseminated intravascular coagulation, or DIC, which I think you guys will learn about in Acute 2. And this is going to be where we have a whole bunch of little clots form inappropriately as a part of it's supposed to be a protective factor for the body, but the body kind of goes overboard with it, creating a whole bunch of clots, using up all the platelets in the blood, and those little clots end up getting put into the small or obstructing blood flow through small capillaries, such as in the fingers and the toes. As it does so, DIC then actually becomes a bleeding issue because all the platelets were used up and people are at high risk of bleeding out. It's this weird condition. Look it up sometime. It's really kind of interesting. And you may look really good in acute too. And the other potential option for developing gangrene in people with meningitis is that when they are septic, they can go into septic shock. They may end up using Levophed, which is another form of norepinephrine. And with the use of long-term norepinephrine, like even over the course of a few days, they run the risk of constant blood vessel constriction, which may end up then leading to tissue death from a lack of tissue perfusion. So just kind of a couple tidbits there for you on why you might see limb loss and gangrene from meningitis. They can also experience hearing loss, cognitive and memory problems, seizures, kidney failure, shock, death, a lot of things that come with the impact of such a significant septic issue. All right, spinal cord and peripheral nerve disorders. These are all spinal cord problems we can have. Sclerosis, whenever you see sclerosis, by the way, this is Greek for, or comes from the Greek word for scar, so that means something is scarring over. Multiple sclerosis itself is an autoimmune disorder, whereas ALS is a nervous system disorder that actually destroys the nerve cells, whereas MS is actually just destroying the myelin sheath around the nerves, around the neurons. So this is what it's supposed to look like, all those little bumps from the oligodendrocytes. Here we've got only a few oligodendrocytes and some empty space, which does not conduct nerve impulses very well, and so things don't travel very well. MS can be immunologic, genetic, or environmental. Generally, it's diagnosed earlier on than ALS is, and it's diagnosed in women more often than it is men, and more so in those who are of a Northern European descent. MS has more cognitive impairment compared to ALS, but it also has less of an impact on mortality. MS also affects more regions of the body compared to ALS, which normally affects mostly just your CNS. So yeah, there's that. So we've got we can have visual disturbances, loss of sensation, limb weakness, bladder and bowel dysfunctions, cognitive issues like depression and paranoia, as well as an inability to concentrate or having memory loss. You can also have muscle spasms. MS has, from what I recall, a decrease in lifespan by about 7 years compared to someone who does not have MS. So people can live a very long life with MS, but they will have a significant number of impairments throughout the entire body because of MS. Some people are lucky enough that they can have exacerbations and remissions and go years without any symptoms, but then have a whole host of symptoms from exacerbations, which can come from heat or infection, trauma, stress. So a lot of what happens with MS is we try to teach people to avoid as much stress, trauma, infection, and heat as possible, but there's no guarantee that they're not going to have another exacerbation. ALS is, again, a nervous system disorder, more likely to be a genetic or inheritable mutation compared to MS. But otherwise, the cause is generally unknown. It affects the motor neurons more often than anything else. So we're looking at an inability to control the limbs, control breathing. People with ALS have a much higher mortality rate than those with MS. ALS, the average lifespan after diagnosis is about 5 years, even as low as 3 to 5 years. Has a later age and onset and affects men more often than women. So people with ALS are going to have weakness, atrophy, cramps, stiffness, irregular muscle twitching, hyperreflexia, and to break it down a little more specifically, in the upper motor neurons, because the motor neurons are what are mostly affected here. In the upper motor neurons, we have mostly hyper or high activity activity. So like hyperreflexia, so exaggerated responses when deep tendons are affected. A positive jaw jerk, so you tap them uh, near the chin, below the lip, and they have a pronounced jerk that shows in their jaw. They also have spasticity in their upper motor neurons that shows as increased muscle tone and stiffness leading to awkward motions or movements. So as you can see here, his fingers and his wrist are all kind of cramped up. They're spastic, they're rigid, um, and that's classic for ALS. On the lower end of the body, we're going to have muscle weakness. So they're not going to be able to walk well. They're going to be wheelchair bound pretty quickly, more than likely. They'll have muscle atrophy, which will make it even more difficult. And then fasciculations are going to be very tiny little, not like seizure-like activity, but little muscular movements that are involuntary in the muscles. So moving on now to spinal cord injury. As usual, males who are young and reckless are 3 to 4 times more likely to experience a spinal cord injury. Usually come from traumatic issues or events like motor vehicle crashes, falls, gunshots, sports. The impact to the cord itself can be through a compression, a transection, which is literally like cutting it in half, or a contusion, like a bruise. We can have different mechanisms, such as flexion, where the neck folds forward, hyperextension, where the neck goes backwards, or compression, where the two forces up and down compress the spine. What kind of an impact on the body it makes depends on where along the spine the fracture, or not the fracture, but the spinal cord injury occurs. If it occurs at C4, they're going to be completely paralyzed, tetraplegia, from basically the base of the neck down. C6 means that you'll at least have your upper chest or shoulders that are able to have sensation and movement. T6 injury means that you will have your arms, but you won't have your torso necessarily that you can use. L1 means that just your lower or your legs, lower limbs, will be affected. With spinal cord injuries, we can have spinal shock, which looks like it's a full-blown paralyzation, but it's actually just a temporary loss of reflexes below the level of injury. The muscles are going to be flaccid. There's not going to be much in the way of sensation. It comes from just a sudden injury, a protective mechanism from the inflammation, but then they return, and they return with spasticity as opposed to flaccidity. Neurogenic shock is going to be something that can occur from many different types of neurologic or spinal cord injury. And when it occurs, we end up getting a legitimate shock, not like a shock as an electric shock, but as in like one of the main types of shock. So we can get like cardiogenic shock, septic shock, neurologic shock, hemorrhagic shock. Neurogenic shock comes from peripheral vasodilation. So everything, all your blood vessels and your systemic vasculature end up dilating. And that ends up leading to hypotension, bradycardia, and overall circulatory collapse. This is a very significant issue. And so we'll be treating this with things like dopamine, epinephrine, a number of things. I actually don't remember everything we use for neurogenic shock. With general spinal cord injuries, we treat with high doses of methylprednisolone to try to prevent the inflammatory impacts that lead to a secondary injury. So we want to try to make as hospitable environment as possible for potential recovery of any kind of sensation and function. We also want to promote intensive, super intensive rehabilitation to maximize function and the ability to recover.